Okay. So welcome everyone. Welcome. Today's Community Cares Project Echo session is going to be on pancreatic cancer. As we may or may not know, November is Pancreatic Cancer Awareness Month. So we are going to have a wonderful session for you today. I looked through the slides and so much stuff that I had no idea about. So such a devastating disease. So it's wonderful to learn a little more. So as you know, for echoes, please keep your microphones muted during the presentation. If you do have any questions, please feel free to use the chat box. What we'll do is we'll have all the questions at the end of the presentation. And just as a reminder, we are recording. Oh. So just remember, as a disclaimer, the information contained in this presentation is not a substitute for a medical consultation. You should always consult a physician if you have any health problems or any treatment questions for yourself. And today's agenda, so we will do our Project Echo overview. We'll do an introduction of Carmela. You'll have the presentation, a case study, and then we'll do our Q&A forum. So I will get us off started on what Project Echo is. So the Rutgers Cancer Institute became a Project Echo hub in 2021. Project Echo is a movement to demonopolize knowledge and amplify local capacity to provide best practice care for underserved people all over the world. So the ECHO model is committed to addressing the needs of the most vulnerable populations by equipping communities with the right knowledge at the right place at the right time. So this is done by using technology to leverage scarce resources. We're sharing best practices to reduce disparities. We're applying case-based learning to master complexity, and we're evaluating and monitoring outcomes. So for more information on Project Echo, you should visit their website. So I'm very happy to introduce Carmela Hofling. She's an MSN AOCNP APNC. And she's an advanced practice nurse in GI surgical oncology. So I'm going to throw it over to Carmela.
Thank you, Evelyn, and good morning, everyone. I can't believe the turnout this morning. Some people so bright and early. Thank you for joining. My name is Carmela Hofling, and I work at the Rutgers Cancer Institute of New Jersey. And I've been a nurse practitioner here in the Division of Surgical Oncology for almost 22 years now. And I've worked in many areas here, but the mainstay and my true love is GI surgical oncology. So I will be talking about pancreas cancer today, something near and dear to my heart. And, Evelyn and I were talking, I don't even think you need to be in the medical field to know what a devastating disease that this can be. So I'd like to just share a little bit of my knowledge about it with you all, given that it's Pancreas Cancer Awareness Month. So we have a couple pre-test questions, and we're going to answer them at the end of the lecture during the post. Is that right, Evelyn? Or they should answer it now?
They're going to take the pretest, and then we'll review the answers after the post-test at the end of the presentation. So if everyone can please answer these three questions, that would be great. So pancreatic cancer average lifetime risk is 1 in 67, true or false? Diabetes and obesity may increase pancreatic risk, true or false? Surgery is a treatment option for pancreatic cancer, true or false? And I'll let the poll hang on for about a minute or two, and then we can move on to the next slide. So if everyone can please answer the three poll questions, that would be great. I'll give it about another 30 seconds. Okay, we're going to go ahead and move on.
Okay, so this is a picture of the pancreas. Um, you can see that the head of the pancreas, which is the most common site for a pancreas tumor, is kind of nestled in the first portion of the small bowel, your duodenum. The body, it kind of lays across the midline of your body with the tail snuggled up kind of near the spleen. Okay. And we'll go into a little bit more about location in upcoming slides. So the pancreas has several functions. Pancreas can secrete enzymes that help break down carbohydrates, fats, proteins, and acids in the duodenum. It also secretes a bicarbonate that can neutralize gastric acid. It also secretes the hormones insulin and glucagon, which help regulate our blood sugar. Statistics for pancreas cancer: more than 64,000 Americans were diagnosed in 2023 with pancreas cancer. Of those, there were more than 50,000 deaths in 2023. The 5-year survival is 12%. And I will say about 15, 20 years ago, the 5-year survival was actually 5%. So not tremendous strides, but some strides over the years. And this is actually up 1% from 2022. Patients that have localized disease or limited to the pancreas, there is a 44% 5-year survival, which is up 2% from 2022. A person's average lifetime risk of getting pancreas cancer is 1 in 67. Etiology and risk factors for getting pancreas cancer. So you have some risk factors that are modifiable and those that are not modifiable. Modifiable meaning that there's something that you can do to hopefully prevent or change your lifestyle in order to prevent getting pancreas cancer. And the number one risk factor or known risk factor for pancreas cancer is cigarette smoking. And we all know that that's something that is modifiable, that everyone can stop or not start at all. Maintaining a healthy body weight, a healthy diet, and limiting the amount of alcohol consumption are also modifiable risk factors. Type 1, type 2 diabetes are risk factors for pancreas cancer. Type 1, we know generally people are born with that, and it develops sometime at a young age or in your teenage years. Type 2 can be a modifiable risk factor as well. Age, as you get older, the risk goes up. The median age of pancreas cancer diagnosis is 71 years old. Gender, men more than women. Race, ethnicity, we see that more African Americans have a higher incidence of getting pancreas cancer. Family history, 10 to 20% of pancreas cancers may have a hereditary component, but only 7% have an inherited germline mutation that increases their risk. People with a first-degree relative have a 5% increase risk of getting pancreas cancer. BRCA mutation, I'm not sure if anybody's ever heard of that. There's BRCA1 and BRCA2. That is the most common genetic mutation that can increase your risk for pancreas cancer. And other things like hereditary pancreatitis, Lynch syndrome, and familial adenomatous polyposis, or FAM can increase your risk. And also chronic pancreatitis can increase your risk. People get chronic pancreatitis. The most common cause of pancreatitis is excessive alcohol consumption, but there are people that get pancreatitis with no rhyme or reason to it. Signs and symptoms. The number one sign of pancreas cancer is painless obstructive jaundice. And the reason for this is because, like I had mentioned in the first slide, the pancreatic head is nestled in the duodenum, very close to the common bile duct. And when a tumor on the head of the pancreas gets large enough, it blocks that bile duct and therefore blocks the ability of bile to to flow through the bile duct, causing it to back up and cause jaundice. And usually when jaundice appears and patients are diagnosed at that point with pancreas cancer, they're typically diagnosed at a more advanced age, which kind of contributes to the poor prognosis of people. It's being found later than what we would like. Pain is another symptom and it typically occurs in the epigastric or the middle of your stomach and radiates to your back. Back pain is typically a poor prognostic indicator. It signifies that the disease is a little bit more advanced. Weight loss, patients lose their appetite, and these symptoms typically appear several months prior to a diagnosis, where patients just out of the blue have lost their appetite and therefore are losing a lot of weight. Fatigue, digestive issues, bloating, indigestion, gas. These are called exocrine pancreatic insufficiency issues, and I'm going to go into that a little bit more a bit later. People are found to have blood clots before a diagnosis, and that's because cancer can put people in a hypercoagulable state, meaning that their risk for blood clots are a little bit higher. So that could be an initial sign. And diabetes. Sometimes people develop diabetes out of the blue 6 months to 3 years before a diagnosis of pancreas cancer. Next slide, please. So part of the workup is it really depends upon how the patient presents. But if a patient comes into my office and they were found, sometimes they go to their primary, they're having the weight loss or they're having indeterminate pain. Sometimes the physician will order an abdominal ultrasound, and that will usually kick things off. You'll see some dilation of the ducts, and maybe you'll see a mass on the pancreas, whether it be on the head or the tail. Typically, if a patient is found to have, it comes into my office, we're not really ordering the ultrasound as a first line. We're ordering a CAT scan. And if the suspicion, or if we know that they have a pancreas mass, it's going to be a pancreatic protocol CT scan. And really what that is it's the way that the contrast is introduced during the CT scan, which kind of gives us different views of the pancreas as well as the vasculature that surrounds the pancreas. We'll get blood work, and part of that blood work will be cancer markers or biologic markers like your CEI and CA19-9 are our gold standard for pancreas cancer. So we'll get those and see if those are elevated. And we may also get an MRI with an MRCP to kind of look at the ducts of the pancreas and see if they're dilated. And once we've gotten all of these tests and we know that a patient does have a mass in their pancreas, we will send them for an endoscopy. And I was explaining to Evelyn before we started this meeting that it's not a typical regular endoscopy like people think of. A typical regular endoscopy really just looks at your esophagus and your stomach. This is an endoscopic ultrasound, and not every gastroenterologist will do this. It's with a special probe that has ultrasound capability. It's done via endoscopy, but it can kind of get into the pancreas, and it will look at the pancreas. It will stage the lesion for us to let us know how much it invades into the pancreas. It will also look at surrounding lymph nodes to see if there's invasion into the lymph nodes that surround the pancreas. And it also can obtain our biopsy for us to get tissue for diagnosis, so we can treat the patient. So the ERCP part of it is if a patient comes in with jaundice, we have to reverse that. We can't, or else their bilirubin will continue to elevate. So typically during the endoscopic ultrasound, they will do an ERCP, and the gastroenterologist will place a stent to open up the bile duct that eventually will get removed after the surgery. Okay, next slide, please. So the stages of the disease. So stage 0 means that the tumor is confined to the superficial layer of the pancreas and there's no spread beyond the pancreas. We don't really see many of these in our office. typically we'll diagnose as stage 2 if a patient is incidentally found to have a cyst or a mass on their pancreas, and they're getting a study for another reason and it's found by accident, and we deem that a suspicious lesion. We'll bring them to the operating room and remove the tumor, and then long and behold, you see that there is a very early cancer within that. But if a patient is already symptomatic, usually we're well beyond stage 0. Stage 1, it's confined to the pancreas, 2 centimeters or smaller. 1B, pancreas confined, 2 centimeters or larger. 2A, the tumor is growing outside of the pancreas, but not into major vessels or nerves, which there are a lot of that surround the pancreas. There is no spread to nearby lymph nodes, and there is no distant spread. 2B, it's still confined to the pancreas, but could also be growing outside of the pancreas. Now you have some invasion into the vessels surrounding the pancreas, and there is also spread to the lymph nodes, but again, there's no distant disease. Stage 3, it's definitely growing outside of the pancreas and into the vessels that surround it. There may or may not be lymph node involvement, and again, there's no distant disease. Stage 4, the cancer has spread to distant disease. And the most common organ that pancreas cancer likes to go to is the liver, close by. So classifying pancreas cancer. So we have 4 classifications for pancreas cancer: resectable disease, borderline resectable, locally advanced, and metastatic. So your resectable disease, it's confined, like mentioned earlier, to the pancreas and surrounding areas. These are your stage 0s, 1s, and 2s. Borderline resectable are your stage 3. It has grown into major vessels and is defined by the abutment of the SMA, or your superior mesenteric artery, or encasement of your common hepatic artery. There's occlusion of your SMV, your superior mesenteric vein, or your portal vein, with enough blood flow that you can reconstruct it without a problem. Locally advanced is still stage 3, but it's a little bit more advanced. The tumor to artery interface is more than 180 degrees, and the portal vein and the superior mesenteric vein you're unable to reconstruct it. And then metastatic disease is to distant sites within the body. Okay, so here is a bigger picture of your pancreas. And you can see, again, like I explained, that it's nestled into the duodenum, the head, which is the most common site. But you do get your pancreas tail lesions out here that is kind of up against the stomach, and on the farther end, your spleen. As you can see, you have a lot of veins and arteries that are running through the pancreas, surrounding it, which is why when you have a pancreas tumor, that there can be invasion into these vessels. And it can make it very challenging to do surgery if it's particularly abutting an artery. The next slide is just a CT scan showing a pancreatic head tumor. And I'm sorry if it's a little fuzzy, but this is confined to the pancreas, the tumor, and is a resectable tumor. This is a picture of a borderline resectable tumor. The SMV is not completely occluded, and the SMA is not encased or surrounded with tumor. So that makes it kind of like a resectable lesion, but can be borderline. Locally advanced, you have your pancreas mass with invasion into the splenic artery, celiac artery, and hepatic artery. And then I think I did, but I guess I must have taken it out, was a picture of a metastatic disease within the liver. So your treatment options include surgery, which I'm going to focus on today as that's my specialty, chemotherapy, radiation therapy, clinical trials. We use here at Rutgers a multimodality approach. So there are three types of surgery that we perform here. And I will say that most of these surgeries are done robotically. In the past, there was a midline open incision, and depending upon the patient, we will still do midline open incisions. But if at all possible, our surgeries are done robotically, shorter hospital stay for the patient, quicker recovery, just overall better. So the first and most common surgery are for is called a pancreatic duodenectomy. Say that 5 times fast, or Whipple for short. This is for tumors that are confined to the head of the pancreas. And this surgery includes removing the head of the pancreas, part of the duodenum, the gallbladder, part of the stomach, and part of the bile duct. And then we kind of put it all back together. So it's a very lengthy surgery, particularly if it's done robotically, because that takes a little bit more time. But that is the Whipple. Distal pancreatectomies with or without splenectomies, those are really for our pancreas cancers that are on the tail of the pancreas. Our surgeons almost always take out the spleen. And if that's done, there are a series of pre and post splenectomy vaccinations that the patient will need. And then they'll require boosters for the remainder of their life. And total pancreatectomy, and all the time I've been here, it's very rare. I've only seen it a handful of times. And that's if the pancreas is mostly completely involved with tumor. And we really try to avoid this because the patients automatically are become a diabetic, and the diabetes becomes very brittle and difficult for patients to control. Surgery is the only potential curative treatment. So if you're able to have surgery with pancreas cancer, that's your best option. More than 80% are found to be unresectable or metastatic at diagnosis. And why is that? So a lot of times it's like I had mentioned earlier, it's a lot of patients when they go to their local doctor, they present with a lot of symptoms that could be chalked up to anything. Weight loss or new onset diabetes. And so that kind of delays diagnosis. And, when they come to us and we have imaging and we do all this work up front and they look like they're resectable, but then sometimes when they go to the OR, they're found to have some disease that wasn't seen on imaging, either in the liver or in the abdomen. And so then we can't proceed with the surgery at that point. So, surgery, there's always a question of whether we should do what's called neoadjuvant first, give a patient chemotherapy, or if we should do surgery first. And surgery is sometimes questioned if patients have a lot of medical issues. If you're not able to get what's called an R0 resection rate, meaning why are we going to do this big surgery if we go in there and we can't get it all out? And there can be a high recurrence rate. So there are a lot of proponents for doing neoadjuvant first, giving them a dose of chemotherapy, because it's known to show that it can help with metastatic disease or micromets that weren't seen on imaging. It can increase your ability to get an R0 resection rate. It decreases lymph node involvement. And imaging, like I mentioned, it's not always accurate. We do here neoadjuvant therapy for borderline resectable and locally advanced here. Unless a patient is really clearly resectable, we will likely recommend that they get some chemo up front first. And I already discussed minimally invasive or robotic surgery versus open. Robotic is preferred over an open. So postoperative complications include, there are several, it's high-risk surgeries. The biggest complication is a pancreatic leak. And this is when everything's put back together, that's called your anastomotic site. And there can be a loss of integrity at that site, which can result in the development of an abscess, fistula, or sepsis for the patient. It is the major cause of morbidity and mortality, affecting up to 41% of our patients that go to surgery. And that's a pretty big number. Abscess accounts for about 6 to 11% of the postoperative complications that we see. It's the most common cause of prolonged hospitalization or readmission. And we typically treat this with a percutaneous drain that the patient has for a period of time and antibiotics. Hemorrhage is rare, but is a life-threatening complication. It's usually a result of the gastroduodenal artery or hepatic artery leak. It's emergent. It's either treated with an emergent laparotomy, or the patient's brought to CT angio for an embolization. They may require a stent or graft. We also give a lot of supportive therapy, IV fluids, blood transfusions, and vasopressors, because they're likely hypotensive as a result. Thrombosis, there's an increased risk of this related when patients have to have their portal vein resected and reconstructed, and anticoagulation, and usually for a pretty lengthy period of time is the treatment for that. Delayed gastric emptying accounts for about 14 to 30% of our patients. Signs and symptoms of this: patients really come to our office, they're not feeling very good, they're feeling nauseous, they may be vomiting, they don't want to eat, they're bloating, they get full quickly. And basically, we like to treat the underlying problem, modifying their diet. We may give a prokinetic like Reglan that helps with motility, helps with the nausea, vomiting. It kind of pushes things through faster for the patient. We may give them an antiemetic like Zofran. And that will eventually resolve on its own with some time. Infection is another common complication that we will treat with antibiotics. Exocrine pancreatic insufficiency. I will say I don't have the number for how many of our patients experience this, but subjectively, I think at least half of my patients come in complaining of this. So basically what that is like I had mentioned in the first slide, our pancreas secretes these enzymes that help us break down our food. And, when we have pancreas surgery, we can interfere with that ability for those enzymes to break down our food. And so patients experience a lot of bloating and digestion. They may have greasy, floaty stools. And, it's typically diagnosed based on symptomatic complaints. And, we then will prescribe enzymes that the patient take orally with their meals to do the job that the pancreas should be doing naturally on its own. And, if patients sometimes need one with meals, I have patients that take 4 or 5 with each meal. It really depends. I usually start low and titrate up based on how they're responding to it. And the biggest problem with these medications is that they're very expensive. And for some reason, Medicare does not do a good job at covering the copay. So I find if patients really can't afford this, that they're suffering with their symptoms. And I'm at a loss for it because this is a surgically induced problem. It's lifelong. We do a lot of the pharmacology or pharmaceutical companies will work with us and give free samples and help a patient out and that sort of thing. But, it's a big problem that we see. And then obviously acute cardiac events, patients can have MIs and things like that just from the stress of the surgery or being under anesthesia for a prolonged period of time. So my case study is DN is a 63-year-old male who has a history of diabetes type 1, coronary artery disease, hypertension, and MI, who presented to the emergency room with painless obstructive jaundice. He has a strong family history. He had a first-degree brother. He had a first-degree relative. His brother died of pancreas cancer. So we know that he had a 5% increased risk of getting pancreas cancer, as well as the fact that he had type 1 diabetes and he is a smoker. He was of normal body weight. So when he came to us, his bilirubin was significantly elevated at 13. His transaminase levels or his liver enzymes were elevated. His CA19-9, that cancer marker or biologic marker, was elevated at 509. He had an ultrasound of his abdomen, which showed a mildly enlarged common bile duct. The MRI, MRCP showed a cystic area at the head of the pancreas. It was about 1.5 centimeters, and there was a whole lot of dilation of the ducts going on. He went on to have a pancreatic protocol CT scan, which confirmed the presence of a mass on his on the head of the pancreas, and it actually was deemed larger than what was seen on the MRI, with some peripancreatic lymph nodes. So ultimately, we sent him for the endoscopic ultrasound with ERCP. The lesion was 3.5 by 3 centimeters. It was irregular. It was abutting, so touching the portal vein. There was some common bile duct dilatation, and the tumor ended abruptly. The duct, I'm sorry, ended abruptly at the level of the mass. So there was a stricture. So a stent was placed, and the biopsy confirmed an adenocarcinoma. So on the next slide, we started him on neoadjuvant therapy. So even though I don't give it, the most common systemic therapy given for pancreas cancer is FOLFIRINOX or gemcitabine with Abraxane. FOLFIRINOX has a lot of side effects, but he was given 7 cycles of this, which appeared to be working for him because his CA19-9 was downtrending. So then they switched and gave him gemcitabine with radiation. And that was most likely, the radiation is not always given preoperatively. That was probably given because of the abutment of the portal vein. After the completion of his treatment, his CA19-9 was normal at 20. The size of the tumor was pretty much the same. So we took him to the OR, and he had a robotic Whipple. And the pathology showed that he had a well-differentiated adeno, which well-differentiated, I don't know if many people know, is better than your poorly differentiated or your dedifferentiated. It has a better prognostic feature, but he did have a lymph node that was involved. So we gave him some chemotherapy, some more FOLFIRINOX, 6 cycles after surgery. We followed him. He went into surveillance. Typical surveillance is the biologic markers, so your CEA and your CA19-9, every 3 to 6 months, along with pancreatic protocol CT scans every 6 months for the first 3 years. And then if the patient is doing well after that, we go into annual follow-up. This patient is currently 3 years out, and he's still doing great. So that's about the gist of my talk. Does anyone have any questions?
Anyone? Oh, here we go. What causes the cancer to be so aggressive to mortality? Is it just because most people find out too late, or due to the post-operative complications mentioned? And then there's a follow-up. How can the symptoms be recognized as risks to pancreatic cancer a lot earlier? That's a great question.
That's a great question. I think that the mortality is a combination of things. I definitely think that the biology of pancreas cancer is very aggressive. And so, you have a lot of cancers where we won't recommend chemotherapy if it's an early stage. I mean, your colon cancers, we don't give chemotherapy for stage 1, stage 2. Pancreas cancer, even with a stage 1, we more than likely will recommend chemotherapies because it's just really aggressive, as you can see. I think postoperative complications significantly increase the mortality rate for patients. I think your health going into the surgery. I mean, if you have a lot of pre-existing conditions before you even get the diagnosis, that will increase your mortality risk. And then symptoms. I mean, I have, you can't blame the local physicians because these symptoms are just so vague and can be attributed to so many things. But I will say that, patients that are diagnosed with diabetes, and if they're doing everything the right way, their body weight is healthy, they have no risk factors, to me, could potentially warrant a little bit more of an investigation. If you have somebody who's coming and saying, I'm losing a lot of weight for no reason at all, I mean, that to me would raise an eyebrow to kind of do a little bit of investigation. I just, I don't really know how to answer that because I do think that some of the symptoms are very vague and so they can be chalked up to other things. And I just think that also the way that the pancreas is situated in a patient's in our bodies, that it's just, a lot of times until that bile duct is blocked, people really just have no idea that it's even there or going on.
Okay, so I have a clarification question. I'm not sure if I understood correctly, but did you say that sometimes pancreatic cancer issues get confused with liver issues?
No, I don't believe I said that. What I said about the liver was that if pancreas cancer is to spread, the liver is the first place it will go to.
And then the next one is has anything been done at policy levels to have the post-op meds covered by insurance?
That I don't know. I mean, I know that our nutritionist here is a big advocate for, working with the pharmaceutical companies and getting these medications, but it's really Medicare is difficult. I will say, we even follow people with cysts or on their pancreas that we're not recommending to take out, and they fight us on even drawing non-invasive blood work, those markers that we spoke about. They won't even pay for these markers to which could be a really good tool to keep an eye on a patient, but they won't, and they're expensive. They're about $300-400. But whether or not anything's been done at the policy level, I don't know.
Carmela, does that have to do with guidelines? Are there like specific guidelines for pancreatic cancer testing, screening, and that kind of
Well,
thing?
I mean, for us, the guidelines, I mean, I would say when there's no diagnosis, there's really no guidelines. For us though, when if a patient comes into us with something on the mast cell, on the pancreas that we don't know what it is, we always like to get those markers. We like to get good imaging and possibly depending upon, I mean, there's so many things that go into working up a cyst, size of it, what it looks like, if there's dilation of the ducts, so depending upon how it looks, then we will recommend that the patient go for that endoscopic ultrasound. I mean, the endoscopic ultrasound is a great test, and it's one that we really have only had for, if I was to venture to guess, 10 to 15 years. It has not been around as long as I've been doing this, and it's a wonderful, wonderful test. The problem is it's not without its problems, right? So it shouldn't be taken lightly to have the patient have that. It can increase your risk of inducing pancreatitis. You can perforate somebody by going down. So we really look at the bigger picture and how a patient presents to us before we recommend certain tests. But to answer your question, when a patient comes in with anything on the pancreas, we always like to get those markers, but insurance doesn't always pay for them.
Okay, we have more. What advice do you have for folks who have a family history and a known genetic mutation? ATM.
Well, known genetic mutations, we do have a protocol on how we follow them. We do get surveillance imaging. So I find here that whether we get an MRI or a CT scan periodically, which one we get is really surgeon dependent. I have one surgeon who he just wants pancreatic protocol CT scans, and I have another one who likes to follow with an MRI. I personally like the MRI because I think overall, if this is a test that we're going to follow a patient for, it's a safer test. gadolinium with the MRI contrast is a lot safer than the CT scan dye that we give our patients. There's a lot of radiation with CTs, so I don't order that, unless we really have to, because I think that it increases patients' risks of other problems down the line if we get too many.
Any symptoms often similar to IBS issues?
Well, I mean, I guess, so I had mentioned EPI symptoms after surgery. Patients that have tumors on their pancreas can have EPI symptoms. So they're, it's hard I'm cautioning to say, because I don't want everybody running to the gastroenterologist, oh, I have gas and bloating, do I have something on my pancreas? But I mean, patients can present with EPI symptoms, so bloating, indigestion, those IBS type symptoms, because there's something on their pancreas that's interfering with the excretion of, or the release of the enzymes. So, yeah, they can have IBS symptoms and have a problem with their pancreas.
I had one that was sent directly. Um, Signs and symptoms seem to all lead to late stage diagnosis. And that actually was another question I have, like how common is it finding it at stage 1? But then the rest of the question is, are there any known or emerging best practices to help identify pancreatic cancer before these symptoms emerge, leading to earlier stage diagnoses?
Um, what was the first part of your question,
The
Evelyn? I'm sorry.
first part was, oh, sorry. Are there any known or emerging best practices to help identify pancreatic cancer before the symptoms emerge?
Honestly, I'm just a big proponent of taking care of yourself and those modifiable risk factors that we spoke about. Cigarette smoking is huge. And not only, I mean, people think they associate it with lung cancer, but cigarette smoking is a risk factor for so many cancer. Obesity is huge with so many cancers. So I would start by doing our best to lead a healthy lifestyle, minimal or I shouldn't say no alcohol consumption, but everything in moderation. A healthy lifestyle, a healthy body weight, no cigarette smoking. But in terms of if you don't have any risk factors, it's difficult to kind of get somebody who's going to order these tests for you to just keep an eye on you, because then everybody would be doing it. Like I mentioned, unless you don't have an indication, to me, the biologic markers in the blood is the best test because it's not invasive and it's just a blood test. But you're not going to get your insurance company to pay for it unless there's an indication. And so it's really difficult. There should be better practices in place so we can diagnose earlier. There isn't.
Do you get a lot of stage 1 diagnoses,
Oh,
or is it
so yes, that
more
was your
at a
first
later
part.
stage?
Yeah, so we see our fair share of cysts on the pancreas or indeterminate lesions on the pancreas. And like I had mentioned, a lot of times patients will get a scan or a study for one thing, and then, oh, look, you have this thing on your pancreas. I mean, we see that a lot here, and maybe because we're a major cancer center, but and not all of them need to come out, but a good number of them do. And lo and behold, we've caught something that could turn into a cancer. So a common cyst or mass on the pancreas is called an intraductal papillary mucinous neoplasm. So that's an IPMN for short. And if you can identify those, now you have main duct and side branch. The main ducts definitely need to come out because they have a significant increased risk for pancreas cancer. And so those patients that we catch them like that, we can prevent them from developing a pancreas cancer down the line. And so they may not have developed one by the time we're taking it out, but we certainly have, eliminated a big risk for them. But they're not completely out of the woods. There's still a risk to them with their remnant pancreas, so we still have to keep an eye on them like we would somebody that we've treated for pancreas cancer. Um, but then we also do surgery on patients that we deem have high risks incidentally found things on their pancreas and that do end up having an early stage cancer. But again, not as common as what we see. We usually see a lot of stage 2, 3, and 4.
And then one last question. What is the average age patients receive preventative diagnostic testing for pancreatic cancer? Do you feel age is important when detecting this disease?
Well, I don't really feel like anybody's doing preventative diagnostic testing unless they have an increased risk factor, if they have a first degree relative or they have a mutation. Um, and I mean, typically patients are older when they get this, but we certainly see our fair share of young folks too. Um, but there's really, unless there's a clear indication, people are not getting preventative diagnostic testing.
Okay. Well,
It's
thank you
really,
so
it's a
much.
shame because I really feel like our insurance companies are a big barrier
Yeah.
um, to what we should be doing and what we could be doing.
And then a lot of other cases as well. So
Yeah.
thank you for that. Let's go into our post test and I'm going to launch that. Oh, sorry guys. Need to move people around. Um, so if you can please take a moment to answer these 3 questions. So the first one is pancreatic cancer average lifetime risk is 1 in 67. Diabetes and obesity may increase pancreatic risk. Surgery is a treatment option for pancreatic cancer. So if we can get just a few more people doing the post test, that would be fantastic. And then when you were talking about reconstruction, you were talking about like actual surgical reconstruction?
Right. The venous, so portal vein. You can't reconstruct the arteries, obviously, but so portal vein reconstruction and those patients, it's usually with the assistance of vascular surgery is in with the surgical oncologist as well. So it's like a two surgeon surgery, but yeah, it can be done.
Mm, okay. Just a few more people, if you can please do the poll, that would be great. And I'm also sticking the eval in for anybody who has to leave right now into the chat. But if we can get a few more people to do the poll, that would be great. Hmm, I think I'm gonna go ahead. Oh, I had a couple more people come in. Okay, I think I'm gonna go ahead and end it and then we can share the results. So the first one is true. Everyone got the second one correct. True. And number 3 is also true. Oh, it looks like another question came in. CA199 is one of the diagnostic tests. Would you recommend adding this as a screening test if this could be done easily? So I guess the barrier is though the insurance companies may not pay for it. So
Well, I
if
would
somebody
love to
wants to
add it
add
to
it
everybody who's
to
got
their
anything.
annual
Risk
physical,
factor,
right?
yeah. I mean, it's the best test to get. I mean, I will say the barrier too, besides insurance company with this blood test, is that with many cancers, typically the markers that are associated with it will be elevated, but that's not always the case. You do have normal markers in the setting of actual cancer, but it is a wonderful tool, and it's not invasive. But the problem is the barrier with the insurance companies, but we do have patients that will pay out of pocket for it.
What do you know offhand, like a general price for out of pocket?
I think between $300 and $400.
Oh, yeah, it's pricey.
But for both, I think for CA199 and CEA.
I guess if you're concerned, I mean, it's worth
Yeah,
it.
I would. I mean, if you're concerned about something, but it is a good screening test. It's not invasive.
Yeah. So, in addition to today's session, we also want to let everyone know about SEED, Cancer Education Early Detection. We have a lot of our SEED partners here, and they help the underinsured and uninsured get screening for breast cancer, cervical, colorectal, and prostate cancers. We also want to thank you for attending today's session. I did drop the eval in the chat, so please, 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 we want to hear your feedback. And let's see. For those of you who aren't on Mighty Networks, we will be sharing the recording of this presentation and any other resources in Mighty Networks. Once you've registered, you have access to everything that we've done this year. So I highly encourage you to go into Mighty Networks and register. And next month, we'll be doing HPV. So I will drop that eval once again into the chat. And if you please, 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 before you drop off, do the eval. Thank you. Thank you so much, Carmela. This was amazing.
Thank you, Evelyn. Thanks everyone for having me. I really enjoyed it.